Hi, I'm Dr. Georgi Brusavanik. This is Dr. Jose Mena. We are spine specialists, and today you are going to hear the first of many spine rounds where we will discuss patients and hopefully you'll get some interesting insight into how the world of spine care really works. So, Dr. Mena, I'm glad we're able to finally sit down and talk about these patients. So, first patient is a 35-year-old mother of one, just had her baby, and I've been managing this girl for about 2 years. She had severe back pain going down to her leg. I call this a herniation. And look, if we scroll down to L45, I think you'd agree, this is a degenerative disc. I mean, look how wide it is.
That's correct.
And then you see this protrusion right in the middle. So I'd say she was sort of acute on chronic back pain that got severely worse, and now she has leg pain.
Correct.
So she got epidurals, as you'd expect me to send this patient for epidurals first. She had good relief, and for about 2 years been managing her. But it got to a point where she said, I can't lift up my kid. My pain is on and off, but she's like always guarding. I can't lift up my kid. I can't stand at the sink. It was really sad. 2 years. I know she had this baby, and she's just suffering through it. So at some point, she was like, I can't take it anymore. So what do we do? So, on the report, this is a herniation. But you and I both know, you go in and you take a little pie slice of this disc, she's going to keep leaking. The disc will keep leaking. Mm-hmm. She'll keep having radiculopathy. She'll keep having pain. And I knew I had one chance with this girl, because she has to go back to childcare. She can't just keep lingering. And she had a number of epidurals.
Correct.
So I said, well, why do we consider a disc replacement? I measured the height. Discs were actually pretty tall in vivo, unlike this other patient that we discussed where you look at the MRI, you're like, oh yeah, plenty of space, and it really was not. And I did a 2-level disc replacement. So going back in terms of how to manage her, where would you start with this girl in terms of epidurals?
So first come to first, I will start definitely first with an exercise program, build the core up. Now, taking in mind that fails, then we start looking at the physical examination. Someone who has a disc like that basically the canal, it's kind of you have an advanced central canal stenosis there. There might be some contact on the quad equina roots there, and some patient might present with weakness. So
that's so insightful of you. So I totally forgot to mention. At some point, as I was managing the herniation, she was getting better. She started to say that she has vaginal numbness.
Okay.
Now she did not become incontinent, but I was really panicking there for a bit because I was like, is she converted to quad equina?
Correct.
You're right on.
Yeah, that will be the first step there, just to look at whether there's some weakness or not on examination, objective weakness. And so the nerve roots that I'm going to be looking there will be the big toe going up, the ankle dorsiflexors, like bringing the ankle up and bring the ankle down, because that's the next nerve root that goes there is the S1.
Yep.
And of course, you're going to be looking for signs of incontinence, bowel bladder. So if any of those are not present, we know that most of the disc herniations, the prognosis is really favorable, so most of the disc herniation is reabsorption. However, the reabsorption rate can happen, but already the disc degeneration is going to still be there. So it can happen again, and that's the reason of making sure that they keep up doing an exercise program. So most likely the radicular symptoms of this type of patients, the symptoms going on the legs, the numbness, the tingling might go away, but the axial symptoms, the back pain, might persist because of the disc degeneration.
That's exactly how it played out.
So that's what we call acute and chronic back pain. But if the patient presents with neurological symptoms, of course, I'm going to skip an injection, and I will be turning a patient to you for mainly a surgical consult, at least, to see whether the patient fits a surgical route or not. And if it will be an injection, it will be a transforaminal guided injection to kind of bring the inflammation down, to allow the body itself. The injection doesn't make the disc to reabsorb itself, it's the body itself. So just to calm the symptoms down, the inflammation portion down, so allow that the disc, so it carries a good prognosis in going back. However, if this becomes more of a back and forth, they do great, but in a couple of months their symptoms are back. It's pointless. And there, of course, they're doing an exercise program. For me, it will be pointless in keeping doing injections because we already know their fate already. Yeah. And those patients, I will be handling those patients to you. But when the injection lasts them for a good amount of time, years, then of course the symptoms, if they ever come back, then I will go ahead and talk to them possibly another set of injections.
Hey, patients ask me a lot, how long will the injection last? Because I push everybody to have
Yeah, correct.
injections. I usually tell them, the medicine is in your body no more than maybe a week. If you don't have symptoms coming back, it's because you just haven't created more inflammation.
Correct.
How do you explain to them how long it will last?
Well, it varies. Normally, yes, the steroid stays in the body about 2 or 3 weeks in the body, then wears off from the body. So basically, fight against the inflammation. So you want to keep doing the exercise program. So the injection might last for a couple of hours as a local diagnostic portion of the injection, which is for you and I will be the most important thing because we just want to make sure our goal will be diagnosing the patient. This is where your symptoms are coming out from. But then we'll look at time. So it can be from complete indefinite, but it can be also short-lived. So as a general guide, like 6 months will be a good cutoff to say whether we can stay conservative or not. So the injection lasts 6 months or more, we can stay conservatively. However, we have to take in consideration, you told me this is a 35-year-old patient, symptoms come back at 6 months, we might talk to them mainly at another injection, but I already will be talking to them, there's a chance that this might be the story, and if this keep coming back, you're 35, most likely you might benefit mainly from a surgical route, which will be different than someone who might be 75 or 80 years old. 6 months is a good amount of relief. So it depends on the patient, but there's no guidelines there that the injection will last you, and I will tell that to the patients. I cannot predict how long the injection might last. However, from the injection, we want to make sure that it provides you a good amount of relief for the hour or two from the local injection, because that's what we need to know.
The thing is, that's always a conflict in my practice, is a patient flies in and says, I've already done injections. And they just call it injections. Right. And we don't know if it's trigger point injections, we don't know if it was bad quality central epidurals as opposed to good quality transforaminals.
That's correct.
So then we go down the rabbit hole of let's find the records. And reliably, you get this packet of records and they have an injection, patient feels better. How much better? What was the visual analog scale? Like, you lose that scientific component. So then, in my experience, especially since I do mostly revisions now, I tell them, you gotta try again.
No, that's wise. And you were surprised that sometimes you get records of injection, and this is not the norm. This is not what you should be expecting, especially if someone is board certified doing this type of procedures. But sometimes you get this type of injection, the contrast pattern is out of place, the contrast pattern does not fit the area. Some people might have adjacent segment disorders, and they call the problem might be at L4-5, and they are thinking that might be the L4-5 level, and they target another level because there is a transitional segment. So you want to make sure that the injection was done in the right location that you're looking for. The contrast pattern matches, and most importantly, the patient provided you a response immediately after the procedure that they got great relief. If that's the information, that's fine. But if we don't have information from records, and it's something valuable that they need that information because of time sensitive, they're having a surgical procedure. Of course, I will agree with you. I will do an injection right on the spot, at least as diagnostic only with local anesthetics. I know that's going to last them for a couple of hours, but at least I will know the control that they got the relief or not.
Absolutely. There's a question about whether proximity of the injection may increase the risk of surgery. There was a recent meta-analysis, and what they showed was that with instrumentation, there is an increased risk. So you should give them maybe a month or two. With a decompression, a discectomy, there is not an increased risk.
Same as a laminectomy, I will say. So they can decompress it without fusion.
I see people like this, where the pathology is there, and some will come in with horrific symptoms, like this girl. 2 years, she can't lift up her kid, she can't lay, she can't sit, everything's a problem. But once in a while, you'll get a patient like this, and I'd say once in a while, probably 10 times a week, where they'll come in with this, intermittent pain, they had clearly either trigger point injections or facetal injections, because the story is I had 12 shots, or I had some crazy things like this. And then they see a surgeon, and they're told, you have to have surgery or you will be paralyzed. And it is so offensive to hear that. And it's become a routine part of my practice. In fact, through social media, I've been talking a lot about this. And I'm bombarded by these poor women, mostly it's women, where they've been told that they have to have surgery. Routinely, I'm having conversations with patients about not having surgery, going back to therapy or injections, because what they were told is just nonsense.
No, the spine, as you know, we all know, the spine is really forgiven. So you can have an advanced stenosis, and patients might be not even presenting with any symptoms, and we get that a lot. Advanced spinal stenosis, barely any symptoms of claudication or even quadriquina. So yeah, I agree with you. In those cases, I will seek literally a second opinion right away. And yeah, there's no chances of telling that you're gonna get paralyzed, especially if the spine is really forgiven.
It's sad, you hear this scared tactics, because really that's what it is.
Yeah.
So, interesting case. This is a 75-year-old man with balance issues, upper extremity weakness, upper extremity numbness. He, when we were in the room, he went like this. He goes, neck pain, and he went like this. And I finished the appointment. It's a neck pain patient with spinal cord compression and radiculopathy. And then I called him at night, and I was like, Robert, you made this impression. It made such an impact on me. He went like this. Were you trying to say that the neck pain isn't really bothering me? He's like, yeah, I'm sort of okay. I take an ibuprofen, and my neck pain is not bothering me. And it was all neurological. So look at this nightmare. C2-3 stenosis. This was really, really tight. Autofusion, and then he's got foraminal stenosis.
Multiple levels.
At multiple levels, exactly. So he had both balance issues as well as radiculopathy.
And instability issues as well. There's I believe there was a two-level C2, C3, and also down here 2, 3, 4, 5, 6, 7, T1.
You got it, but look at the joints.
It's all fused.
Look, I mean, essentially no motion. We got flexion extension imaging on him. Let me show the MRI. It will really, I think, surprise you.
Wow. So there's a cord impingement, definitely C2, C3.
Scary.
But all the levels down are very shut down.
And then look at the foraminal narrowing here. Look at this. I mean, you can't even see the foramen.
Yeah.
So we got him to go back to his pain management doctor. He's from up north.
Okay.
We did 5-6 transforaminals, and it helped with just the upper extremity stuff. He still had balance issues, no surprise. But that one comment he made about neck pain, and he made this flippant sort of hand gesture, I went back and I just went from the back, and all I did was I unzipped him here. I use a bone knife, so it's like this oscillating saw that you can use safely around a spinal cord. And then I decompressed the neuroforamina on the side where it was the tightest. I think it was maybe the right side. I don't remember now. Anyways, complete resolution of symptoms. The guy, so neck pain was never an issue. And I just saw him last week. This MRI, and all I did was decompression. No screws, no rods, no fusion.
This type of clinical presentation, I would have thought, just by looking, obviously I'm not a spine surgeon, but might entail decompression from the back. That's just looking at it, not from the front. There's a multiple levels. Normally, I believe there are 2 or 3 levels that you can only do from the front.
I agree.
Multiple, so it should be coming out from the back. And actually, I would thought that you have been putting some screws there, especially with instability at C2, C3, and C71.
Right.
So in other words, this patient will be someone who will have a stiff neck for life.
For life. And probably would not be able to drive. Because if you're talking about going C2 down to C7, he'll lose at least 50% of his motion.
Correct. And actually, I will think that you guys will extend the fusion down to around T1 or T2 at least.
You'd have to, because otherwise, high risk of non-union.
Union. So normally, you guys extend it out to T2. That will be providing them like a restricted neck. And that will be causing then adjacent level disorder because he's trying to move the neck.
That's it.
So you prevent it from a nightmare later on from pain perspective.
So I see a lot of these patients, and coming from the university, and reliably, as you said, screws all up and down.
Yeah, that's what I would thought.
The problem is, as a revision guy, there's not much I can do once they're fused, now let's say the rod's broken and I have a non-union, okay, I can fix that. But a patient who just has chronic pain from a monstrous operation,
No, that's it. There's nothing else to do.
what about the spinal cord stimulator? Let's say this guy got screws and he comes back with headaches, neck pain, shoulder blade pain, I mean the whole syndrome.
The first thing that I will be looking will be adjacent levels. So the first joint I will be looking will be C1, C2.
Right.
It's fused. Some people develop osteoarthritis. You are able to sneak a needle at C1, C2.
You do those?
Yes.
I have a few patients like this.
Yeah.
Trying to keep them away from
I
surgery.
do
That's
C1,
great.
C2 injections. Normally looking for that. Normally they will have because they're trying to turn their neck when they're driving. So C1, C2 provides more the rotational component,
Yeah.
and it's more likely to break down. So we'll be looking there. Now, if they're presenting with radicular symptoms, I'll be looking at the level below, T1, T2 area, depending where the fusion extended.
Makes sense.
But provided that everything else looks fine, the problem with the spinal cord stimulation in this type of patient actually passing the lead through the spine with a lot of instrumentation there. Already there might be some scarring, so you might not be able to extend to pass the lead. So those patients are likely interventional procedures might not work. So
Very sad.
like might be pumps and stuff like that.
The swim coach came to me a while ago, and he had intermittent pain. He's a prominent guy in my community, and I said, "Don't have surgery," and I sent him away for pain management. But he wanted the best, and who is the best? It's the head of the spine department at a local university,
Okay.
the grandpa.
Okay.
That's who is the best. So he goes to see that guy, and he has the front back, and he comes back to my office, and he's like, "Jose," and he's like, "I want my money back from a visit from a year ago." So we immediately refunded him the money. I think he paid like $500. And I just said to him, "What happened? Like, your money's back. I feel bad what happened to you. What happened? Clearly you had an operation." He says, "I saw the head of the department, and he saved me from paralysis." And his MRI looked nothing like this. There was no spinal cord compression at all. It was just disc degeneration. The guy told him that if he dives into the pool and hits his head on the bottom of the pool, he'll be paralyzed. Like as if any one of us, when we dive in the pool, we won't be paralyzed.
Right.
And to this day, the guy believes that the surgeon saved him from paralysis.
How's the pain right now?
Horrible. He can't swim. He can't turn. He
Of
can't
course.
be a coach anymore. I mean, this was clearly an operation done to the patient, not for the patient.
Correct. In those instances, it depends on the amount of spinal cord compression there. But the problem with those patients having a big surgery, unless of course there's a need for it, will be the long-term sequela. Having a multiple level fusion will restrict your movement at all.
And what you said earlier, Jason Level. Thank you for participating in our spine rounds. Looking forward to having you visit us for the next episode. Thank you, Dr. Mena.
Thank you so much.
Hope to see you soon.
Likewise.